Dear colleagues, welcome to today's webinar on managing iron deficiency in heart failure patients. I am Dr. Josep Comín Colet from Bellvitge University Hospital in Barcelona, and I have the pleasure of being joined by Professor Teresa McDonough from King's College Hospital, London, and Professor Piotr Ponikowski from Center of Heart Diseases in Wrocław. The aim of this webinar is to give you a better understanding of the prevalence of iron deficiency in heart failure and the impact of iron deficiency on heart failure patients in terms of quality of life, mortality, and also hospitalization, and also insights on how to manage it in normal clinical practice. We're also going to learn about the ESC recommended diagnostic and screening criteria for iron deficiency. In one word, how to implement ESC guidelines. We're going to also learn about the recommended treatments options, particularly what is recommended in the ESC guidelines about treating patients with iron deficiency and heart failure. We'll do that through clinical cases presentations. This session is interactive, and we strongly encourage you to actively participate by sending your questions and comments at any time during the webinar through the chat. For the best learning experience, we also invite you to participate in online assessment sessions in the form of MCQs that will be submitted during the presentations. This program is supported by B4 Pharma in the form of educational grant. And now I will hand over to Professor Ponikowski for the presentation. Piotr?
Josep, Teresa, colleagues. Thank you very much for the invitation. It's a great pleasure to be here this afternoon in Paris and discuss with you iron deficiency. As Joseph said, we will be presenting cases. We will be discussing how to deal with patients in everyday clinical practice. Obviously, this is always going to be guideline, recommended therapy, evidence-based case presentation. These are my disclosures. Before I start presenting the case, let me refer and let me make some short introduction. This is one of the most recent and perhaps one of the biggest epidemiological study dealing with patients with heart failure and showing you what actually happened over the last decade. This study shows very clearly that heart failure is now becoming a multi-morbid syndrome with the number of comorbidities reaching 5 to 6 per patient, and with virtually every patient having several coexisting diseases which affect the management. This is why in the guidelines we considered comorbidities as a very important clinical problem. We clearly recognize that both cardiovascular and non-cardiovascular comorbidities, they affect clinical picture, they affect heart failure progression, they affect the outcome. But what really matters and what would be the title and the subject of today's discussion, they affect the management. And if you look here and you see the slide, we were clearly stating that comorbidities are now becoming targets for potential intervention, and this is, I'm sure, more and more data will be coming in the next future. Today we'll be discussing iron deficiency, and iron deficiency was mentioned and actually was clearly recognized in 2016 guidelines. And the guidelines, we said that iron deficiency in heart failure patients is common and important comorbidity, and it affects more than 50% of patients, regardless we are discussing those with preserved, impaired ejection fraction or mid-range ejection fraction. And what really matters is that we should clearly state that it is irrespective of the presence of anemia. We also are aware that, and there is a lot of evidence proving that iron deficiency is associated with decreased exercise performance, poor exercise capacity, poor quality of life, and finally, which is of key importance for us, it worsens their prognosis in our patients. This is the cartoon we prepared together with my colleague Eva Jankowska, with whom we are working on iron deficiency over the last couple of years, and it shows very clearly that iron deficiency affects two parallel pathways. One is what we intuitively link iron deficiency with, is anemia, and it is still common. Iron deficiency in half of patients is associated with low hemoglobin level. That's true. But in another half, iron deficiency is present with normal hemoglobin level and affects all these non-hematopoietic pathways, of which mitochondrial dysfunction, effects on energetics, effects on all these biological effects, including reactive oxygen species defense, all these kind of still not well-known mechanisms are affected, and it is why iron deficiency in both pathways is leading to deleterious biological effects, and that's what we are seeing in everyday clinical practice. Again, referring to the guidelines, I need to say that in 2016, based on existing evidence in 2016, we stated that iron status should be evaluated in all newly diagnosed heart failure patients with class 1C recommendation. And we also recognize that iron deficiency diagnosis is not difficult in clinical practice, and these are the biomarkers which reflect iron deficiency. As you see here, ferritin level reflects iron storage, the pools of iron stored in the body, and transferrin saturation reflects iron utilization at the periphery. So in the guidelines, we recommended that blood biomarkers reflecting iron status are serum ferritin and transferrin saturation. Obviously there are more, and I'm sure that we'll be discussing this later on, but these two are the fundamental biomarkers for the diagnosis of iron deficiency. We also mentioned that both ferritin and transferrin saturation assessment should be performed simultaneously. And one very important message, iron deficiency evaluation, and I will show you the flowchart, the algorithm Professor McDonough developed. Iron deficiency and anemia should be evaluated together, and in the case of anemia coexisting with iron deficiency, we should always be aware that there may be some underlying causes of anemia which we need to establish and treat if necessary. So let me start with the case, which I already promised to start with. This is a patient with 71-year-old gentleman with ischemic heart disease, with non-STEMI in the past, with several coronary interventions. He's diabetic, he's with hypertension, he's ex-smoker. His heart failure diagnosis was established already 5 years ago, but 2 years ago he had his last echo done with ejection fraction in the range of around 40%. Since then, he was pretty stable, but only recently, a few months ago in January this year, he developed episode of heart failure decompensation due to viral infection. He was in the hospital, he was discharged, remained stable, and now he's referred to our clinic. He mainly complains of shortness of breath or moderate exertion. There are no symptoms addressed, no angina. His medical therapy comprises of ramipril 10 milligrams daily, bisoprolol 5 milligrams daily, eplerenone 25 milligrams once daily. So in other words, all these three elements, all these three components, guideline recommended therapy, ACE inhibitor, beta blocker, and mineralocorticoid receptor antagonist are there. He also receives statin, aspirin, and metformin for his diabetes. He's euvolemic with blood pressure 130/75, resting heart rate around 75, and ECG sinus rhythm with narrow QRS complex. He has moderately impaired renal function and pretty well compromised diabetes. So from the first impression, we may say patient is optimally treated. Most likely he is relatively low-risk patient, and perhaps we should continue with the therapy, and we should send him back, say, in 4 to 6 months. And today, now I would like to pose first question, what is the risk of death in this patient, as I said, perhaps optimally treated within 1 and 3 years?
Okay, that's a very interesting question. Sometimes certification is not easy. And we have some time left for answering the question in the audience. And actually we got back the answer. So most of the, in the audience, they were in favor of the last option, very high risk. Now it's changing because new votes are coming on, right? So it's about 26-27% for the last two options. So many of you say that's about between 10 to 25%, and one-third would be around very high risk. So most of you, and the answer are consistent that the risk is moderate to high risk.
And how many, Joseph, are saying that he's relatively low risk, kind of a few percent 1 year
13%.
and few... Okay.
13%.
So I'm
still think there's a low risk patient.
So I'm very glad that the audience recognizes that despite this patient is sort of stable and treated like a guideline recommended to treat this patient, he is not that low risk as it may well appear. This is the very famous kind of and well recognized MAGIC score, and according to this MAGIC risk score, his risk of dying within 1 year is 11%, and the risk of dying within 3 years is nearly 30%, which clearly shows you that if you compare this with malignant diseases, 10-11% of death 1 year, and 3 years, nearly 30% is actually pretty moderate to high risk, as most of the audience says, which is I am glad that that the colleagues recognize. So we believed, it was a June visit, that the patient is not optimally treated. We believe that he needs additional evaluation. Remember that echo was done 2 years ago. There were only very basic laboratory assessments. Perhaps based on what we see, we would go for other investigations, maybe angio. I'm sure that Teresa has got a very strong feeling about angio, but angio was not recommended as a first instance. Then we decided to modify pharmacological therapies. We decided to replace ramipril with sacubitril valsartan. He was diabetic, so we believe that metformin alone is not the ideal scenario. And at that stage, remember that it was June, the HF trial was not presented yet, but still a lot of data showing that SGLT2 inhibitors should constitute a therapy here. Remember that heart rate was above 70, and I'm sure that we all agree that this fast heart rate in those with sinus rhythm may well be, and HFrEF, may well be a target for intervention. So here ivabradine or bisoprolol, remember 5 milligrams, and pretty well established blood pressure. This is why we increased bisoprolol to 10. And obviously devices, ICD, not CRT, because he was with narrow QRS, and maybe some additional decisions after receiving the results. I don't know whether you want to comment on that, because then I show you what we did. Else.
No, I think in this situation you have to optimize everything you can optimize in terms of guideline-directed therapies. And obviously time had moved on, sacubitril valsartan had good evidence for HFrEF. As you say, the SGLT2s had good evidence for treatment of patients with diabetes at high cardiovascular risk. So, and you upped the beta blocker to the...
And then we see
what happens.
That's what we did. If you look at the echo, there are some additional findings. Ejection fraction dropped to 30% from 40. There were some new regional wall motion abnormalities. We discovered something new, which was already present at the physical exam. There was a systolic murmur suggestive of mitral regurg, and here we see at least moderate, if not severe, mitral regurg, and we confirmed moderate renal dysfunction, but we discovered hemoglobin 12.3, ferritin 87, and TSAT 22. Again, I would like to have your opinion whether you would send this patient for angio, or you would be a little bit afraid that it is not really going to help him. We can discuss this. what would you do with this functional mitral regurg? Shall you intervene with mitral clipping now? Everybody is so happy to do it. And final question, which I am keeping up to my sleeves for the next, what about iron deficiency? I don't know, what do you think, Giuseppe, Teresa? What about angio? Is this you hesitant, or you would...
I don't know what you think. I mean, probably in this case, particularly this case, with no symptom of angina in a patient with some room for improvement in terms of drugs, and probably I would really wait a little bit for angiography to be evaluated at this point. It would be different probably for a patient that complains about symptoms of angina, or really you have really evaluated all the other options. Well, what do you think about that?
Yeah, I mean, I tend to be, like you, quite conservative with angiography in heart failure patients if they don't have angina. The only thing is that the patient has type 2 diabetes, and sometimes they don't present with chest pain, and there is a new wall motion abnormality, so I think I would have erred on the side of at least scheduling a non-urgent angiogram.
This is exactly what we did. So in other words, we share the same kind of a way of thinking. There is no indication for urgent angio, but typical in our condition it takes 6 to 8 weeks. But for the time being, we've dropped to 32 with new regional wall motion abnormalities, with secondary mitral regurg, maybe some stuff to improve. So no rush. On the other hand, we felt that it may be appropriate to see. Obviously, we can debate whether we should intervene based on what happens. I can't tell you because it was not performed yet. But anyway, so what about then iron deficiency? What do you think? This is my next question, and I would like you, Joseph, to take over and then see what do you think.
This is the question. I mean, actually, first of all, the way we diagnose iron deficiency. So you got now, in this case, whether or not the audience will diagnose iron deficiency. Remember that the patient has got 12.3 HB, ferritin 87, TSAT 22%. So we have some seconds left for voting. So go ahead. What do you think? Using two different parameters for diagnosing iron deficiency is something that has helped to spread the word about diagnosing that. Is it a complication? What do you think?
Well, obviously the guidelines recommend two. One of them is well below the mark. The ferritin's less than 100. So I think that his hemoglobin's also on the low side. I think I would be ignoring the TSATs in this case, and
TSAT is borderline, isn't it? 22%, so 22%. It can be. Do you guys believe that ferritin and TSAT is enough, or would you go for additional parameter? I entirely agree with Teresa. More often we're seeing patients with lower-ish TSAT than with this lower-ish ferritin. This is why I wanted to show you this guy. But do you go for ferritin and TSAT, or you go for iron, for this different kind of MCV and all this kind of stuff, or you're rather happy with two fundamental biomarkers?
In our case, we usually stick to ferritin and TSAT. In some cases with that, in borderline cases, we may use STFR in some cases. But mainly ferritin and TSAT is the way we use to diagnosis.
Yeah, I mean, a few years ago, we just used to put hematinics on the blood form, and all sorts of things came back, including serum iron, TIBC.
Yes, that's it.
And I think we've simplified it a little bit now for those of us that are not hematologists and not ironologists. And I think the TSATs and the ferritin in most cases are enough, until I think we get a better biomarker. I mean, I know there is interest in hepcidin, but the other things at the moment seem to be more difficult to interpret than the ferritin and the TSATs.
What is the audience saying?
We have, the audience have a clear answer. 85% they say yes, this patient is iron deficient.
Good then, so why not we ask a second question, actually third one, which I will again hand over to you, Giuseppe.
Okay, so we got the diagnosis of iron deficiency, and would you start treatment to replete iron deficiency? This is a clear-cut question about once you diagnose that, you should do something or not. And you have some seconds for answering that. I mean, you are experts and you are clinicians, so probably you have your idea. But in terms of treatment, which is the right moment to really decide to treat iron deficiency or not? I mean, we have the guidelines, we have a flow chart telling us each step, but where do you fit iron deficiency evaluation and treatment in these patients?
I think I would treat the iron deficiency at the same time that you're doing the other things, such as optimizing the therapy. There are two aspects to it here. The patient is also anemic, so I think you have to look for causes of iron deficiency anemia. So I would certainly be treating the iron deficiency as we're doing all these other things. Yeah.
What the audience says, Joseph?
Oh, so this pretty clear answer, 95% say yes, they would start treatment.
Well, I'm not going to make things even more complicating in asking how, but before I do this, this is I would say, fundamental to understand what to do slide, which I have borrowed from Professor Teresa McDonough, just recently published a very simple step-by-step algorithm. And I'm going to read this for you. We are actually with chronic heart failure, and the patient has reduced ejection fraction, so very important. Then we checked iron deficiency status. Step 2 is check anemia status. This guy is actually anemic. He's not that badly anemic, kind of a 9, 10, but 12-ish, particularly he has never ever complained of this, makes or rings the jingle, no, the bell. Well, today we discussed this, the words, English words. So he is anemic. And what Teresa said in the algorithm, you better check the underlying causes of anemia in this patient, 71-year-old gentleman. So ex-smoker, so you can't really say this is only iron deficiency. We did GI endoscopy, negative. And this is why we now at the step number 3, and we are happy to say we go for the treatment. And as you see, following the algorithm I already alluded to, the next step is actually consider iron repletion, but not with oral iron, but with IV iron, and we will discuss this in a second. In this gentleman of weight of around 80 and hemoglobin around 10 to 14, we are talking about 1 to 1.5 grams of iron. We can't really go with one go, so perhaps we split this in 2 to 3 doses. Actually, we are doing this in 2. And then what Teresa recommends is actually check or recheck everything a couple of months and then recheck and reevaluate after a couple of months, and that's the algorithm we apply in our everyday clinical practice. This is the statement in the guidelines, and this explains why we are discussing IV iron with ferric carboxymaltose, because only ferric carboxymaltose, which is IV compound, was tested in clinical trial, FAIR-HF and CONFIRM-HF. Since the guidelines and since this statement, there are the 2 papers, 2 studies, effect and iron. I only allude to one. This is a study we did together with colleagues showing that there is improvement in 6-minute walking test. So it's a kind of a follow-up of another study which we call FAIR-HF. I'm not going to bother you with the details, but it's a clear evidence that functional status, exercise capacity, as you see here, 6-minute walking test, fatigue score, they are all improved during the therapy once iron deficiency is corrected. But what really matters, and some people may ask, why not to give oral iron? First of all, there are several explanations. There are frequent dose-related gastrointestinal adverse events. It's poorly tolerated. It's not absorbed well. It takes a long of time. If you take into consideration there is a deficit of 1 to 2 grams, it will take more than 150, 180 days to replete iron, taking into account that patient will take this constantly for 6 months. And obviously you can say, what about the results of the studies? There is one study, quite recently published, Iron Out trial, showing that patients who received oral iron, if you look at the left part of the graph, there was no improvement in peak oxygen consumption, and the right part of the graph shows that oral iron did not correct iron deficiency. Biomarkers reflecting iron deficiency stayed virtually unchanged. This is why we do not recommend oral iron, and this is the summary and the take-home messages. Iron deficiency in heart failure patients is common comorbidity irrespective of anemia related to poor exercise capacity, poor quality of life, worse prognosis. Iron status, that's what we discuss, should be evaluated as a part of the initial workup in all newly diagnosed heart failure patients. Iron deficiency, if present, should be corrected. In symptomatic patients, there is enough evidence. We know that we can improve exercise capacity, quality of life, and now we are doing very interesting studies together with Joseph, with Teresa, in order to evaluate whether it also will change the outcomes of our patients. So thank you.
Thanks very much, Piotr. I mean, very interesting presentation and the clinical case. And there is a lot of debate. I mean, there's coming a lot of questions. So I'm going to be challenging you afterwards, okay? I think we need to move on, and I would ask Teresa back there to present the case and maybe discuss from a different point of view the role of screening iron deficiency, checking out and treating in this type of patients. So Teresa, please.
Thank you very much. It's a pleasure to be here with two of the well-known international experts on iron. I'm going to present a slightly different case, and I hope a complementary one to the one we just heard from Piotr. My patient's a bit younger. She was 55 in 2015 when I first met her, and she's of African origin. She had a long history before she presented to myself in the outpatient clinic. She had hypertension for many years and type 2 diabetes. She first was diagnosed with heart failure in 2004, reduced ejection fraction heart failure with a severe impairment of her systolic function with a left ventricular ejection fraction of 23%. She didn't have chest pain at the time, but she did have an angiogram, I think because she'd had years of type 2 diabetes, but the coronary arteries were normal. At that point, back in 2004, she was started on standard disease-modifying therapy for reduced ejection fraction heart failure. She was intolerant to an ACE inhibitor because of cough, but she ended up on candesartan, bisoprolol and spironolactone. She seemed to do okay in terms of her symptoms for a while. Then she presented, unfortunately, with a left middle cerebral artery stroke in 2011. Also between 2011 and 2014, her symptoms got worse, and she had a widened QRS in her ECG such that she ended up with a CRT pacemaker inserted as well. Because she was young, very symptomatic, on optimal medical and at that point device therapy, we referred her for consideration of cardiac transplantation. But unfortunately things had really probably gone slightly too far by then. She had pulmonary hypertension, so she was unsuitable for listing for heart transplantation. The transplant centre offered her mechanical support with an LVAD as a bridge to decision to see if 3 months of LVAD therapy would reduce her pulmonary pressures, but the patient declined that. So at that point, when she's unsuitable for cardiac transplantation and declined mechanical support, we decided not to upgrade her CRTP to a CRT-D device. We came across her again in December 2015 at a routine outpatient appointment after her transplantation assessment, and she was getting symptomatically worse. She was very tired, breathless, on effort, and had lost her appetite. There wasn't too much to see in terms of examining her. Her heart rate was well controlled at 63. Her blood pressure was 100/50. There was no evidence that she had symptomatic hypotension, and she was euvolemic in terms of examination. Her drug list by this stage was, as in all these patients with advanced heart failure, fairly considerable. She was maintained on guideline-directed doses of bisoprolol, candesartan, and we'd switched her to a eplerenone 50 milligrams. In addition to bumetanide, to keep her euvolemic, we'd had to add in a thiazide diuretic. She was on warfarin, and you can see she's on many drugs that suggest she's having complications of advanced heart failure. She had gout and required intermittent use of colchicine, and she was on allopurinol. So we began to think, well, what can we do here to improve the situation? Is her pacemaker working properly? Her ECG there shows that she has atrially sensed and biventricular. She is biventricularly pacing, and her pacing check showed that the pacemaker was in biventricular mode over 99% of the time. That's her chest X-ray. Obviously there's a very large heart and signs of pulmonary hypertension, but we were wondering, had we just got the dose of diuretic wrong, and did we need to increase the dose of diuretics? But she doesn't appear to be in pulmonary edema. This is our updated echo in 2015, and you can see that things are indeed very bad, with severe systolic dysfunction and signs of pulmonary hypertension with the D-shaped septum. In terms of some of the blood tests we did, which may give us some clues as to what we can do next, as you'd expect, she had a relatively high NT-proBNP. She was anemic. I've used slightly different units here to Piotr, so that would be 10.4 grams per deciliter. MCV a little on the high side. Thyroid function tests normal. Of the hematinics that we looked at, this was 2015, so the ESC guidelines hadn't come out yet, and we got, in addition to the ferritin at 125, TSATs at 14, we got a serum iron of 9.8. You can see she has significant chronic kidney disease with a creatinine of 148 and a reduction in her eGFR to 32. So I suppose the question I want to pose is the question we were faced with at the time. And this is just 2015, presenting a historical case here. What are the options to try and make this lady a bit better?
Okay, so now it's the turn of the audience to answer what to do next. There are 5 options, several treatments. So first of all, hydrolyzed nitrate, which is something you may think about in this type of patient, ICD. Secondary valsartan, but it was 2015, so many of us were involved in studies and were, aware about the use of the drug. But IV iron and increased bumetanide, people is voting. Still some seconds left. So, what do you think? Should we always think first in drugs than devices? In this case, or other cases, or what's your feeling about that?
Yeah, well, I think we'd come to the end of device therapy, and I think she certainly wasn't suitable for an ICD. She's been turned down for transplantation. If we think back to Piotr's magic score, this lady is very, very high risk, and her mortality in the next year is 50% at
and
least.
Also she was pretty euvolemic, so bumetanide is not that good option. And what Teresa presented, although in the indication this is in this lady for hydrolyzed nitric, but due to low blood pressure, I would doubt whether she would tolerate these high doses for this Afro-American patients.
And the problem is it has to be added on to the
sacubitril valsartan to replace. But in 2015, in this one blood pressure 100, ejection fraction 18-20, it's not an easy decision.
Okay, so the audience has a similar opinion than you mentioned before, but 42% were keen of initiating sacubitril valsartan, but 50% they say intravenous iron. So
Okay, well, this is a real-life patient, so of course we don't just do one thing. So we started looking at all the things we hadn't done, and the heart failure nurses who'd carefully up-titrated her medication over the years pointed out that she'd never been referred for rehab, which is a Class 1A indication for heart failure patients, and she was symptomatic in terms of her effort capacity, and she had low mood. So we offered her rehab and cognitive behavioural therapy. We did as the audience and Piotr suggested. We decided just to try sacubitril valsartan. We didn't think we had anything to lose. We started her on the lowest dose, which is, in terms of the combination of sacubitril and valsartan, the 50 milligrams BD dose, and our heart failure nurses slowly and carefully up-titrated that to 200 milligrams BD, and she did. Her blood pressure tolerated that, and we did see some improvement in her symptoms. No improvement in her ejection fraction, but she was certainly less breathless on effort, and she didn't have any episodes of decompensation during that time. And her kidney function held out reasonably well. Creatinine really was stable around 150. So this took her to late December 2016. We did go down the intravenous iron route. I mean, she has a number of risk factors. Just thinking back to the epidemiology that Piotr and Eva wrote about a while ago, she's also got other risk factors. She's female, and we know that iron deficiency is more common in women, and it's more common as the syndrome progresses in severity, and she has advanced heart failure. So in terms of her ferritin and TSATs, she's between 100 and 300, but she does have low TSATs, so we gave her 1 gram of ferric carboxymaltose. We again followed the algorithm. I think it's always worth repeating a good algorithm twice.
Yes.
So she was also anemic for a woman, in that her hemoglobin was 10.5 or 10.4, so we did upper and lower GI endoscopy, but we didn't find any GI cause for her anemia, so we proceeded to give her intravenous iron. We used the algorithm. She was 65 kilos, and her hemoglobin is between 10 and 14. So she fits nicely into 1 gram of ferric carboxymaltose, which we gave her. Actually, it did make her feel a bit better. She was certainly less breathless on effort, and such that she actually managed to complete our course of home-based cardiac rehabilitation. She felt less low without getting an antidepressant, and she went back to work actually briefly at this time. We did check the hematinics 3 months later. The ferritin, you can see, is well. She is well iron repleted, and the TSATs have crept up just to above 20%, 21%, and our hemoglobin came up as well with that. So over the course of 2017, she definitely felt a bit better symptomatically in terms of her breathing, but unfortunately her renal function deteriorated, and she became hypotensive, and we had to then stop the disease-modifying therapies with the ARNI, with spironolactone, and with the beta blocker. Her iron status we rechecked several times throughout the year, and our ferritin always remained above 300. But unfortunately, we progressed to a more palliative phase of management, and she died in early 2018. So it's a sad case, but I presented it just also to help, just for people to remember that while we're waiting to see if intravenous iron does improve mortality and hard outcomes in heart failure, that it's very important for symptomatic control, even in advanced heart failure. We do all you can do with the drugs and devices, but to think about these comorbidities, of which iron is one that we have a treatment for, and I hope that it improved her quality of life.
Thanks very much, Teresa. I think it's a very interesting case. Also complements very much what you presented before. There are a lot of questions from the audience, and some of them are very challenging. First, I have one for you, Piotr, because you and your group, you've been studying a lot about mechanisms behind the iron deficiency and the pathophysiology behind the progression of heart failure. And one of the people said, one of the questions said, what is the mechanism of iron deficiency? And I assume iron correction in HFrEF. What is the mechanism? So,
if only I can tell you, it would be great, because then we can target this mechanism. I can only say that although we have a lot of evidence that indeed iron deficiency is common, iron deficiency is related, as we all said, to poor quality of life, poor exercise. So we all see this anemia and non-anemia pathway. If somebody asks, what is this about? Why so many heart failure patients tend to develop iron deficiency, we should say many different reasons. One is obvious, blood loss. Second is obvious, but not dramatic blood, kind of a constant blood loss. Second one, so-called real, not iron deficiency related to the blood loss. It's obvious, so we should clearly state this. Second issue, important issue, is actually a problem with a diet. It's not always, perhaps this case Teresa alluded to, although the young lady, relatively young lady, with loss of appetite, with cachexia a little, it affects a lot of patients. So, and also congestive, kind of a congestion in the intestine, it affects their absorption. Another story is more kind of a pathophysiologically, still not quite confirmed, that in heart failure, like in many other inflammatory diseases, there is a pro-inflammatory activation. And a major compound, a major kind of a small substance involved in the iron metabolism is hepcidin, which is triggered by the pro-inflammatory signals. On the other hand, though, we did the study in more than 400 patients in heart failure across the whole spectrum of the disease, and to be honest with you, we didn't observe that sort of a straightforward relationship with hepcidin level, high hepcidin level, and iron deficiency prevalence. In other words, although we borrowed this concept from renal disease, where it operates well, I truly believe that in heart failure, hepcidin is not everything about, activated hepcidin is not about iron deficiency, or this is not the only mechanism. We actually, I don't have time, but long time ago we developed the concept of iron deficiency as a protective mechanism of some iron overload in the early stages. But again, to make long story short, we simply can't say, but regardless, we know the mechanism or we don't, we believe that we should replace iron. Different mechanisms make it this way. But I am glad that Teresa alluded to the same case as I did. Although we clearly recognize that iron deficiency and anemia should be seen separately, if they go together in clinical practice, we always very scared to understand the underlying causes. And we are not obsessed with this, but we evaluate this.
This is a good point, because it links with some of the questions regarding the diagnosis. One of the questions was, first, what kind of tests, what kind of additional tests do you perform when you study iron status in a patient, particularly if it is anemic or not? So some people want to know.
Well, I think it depends a little bit on the full blood count, because obviously if somebody is anemic and iron deficient, and you know their white count's high, or their MCV is very high, or they're pancytopenic or something, then you have to think about bone marrows and other causes. If it's a low hemoglobin and iron deficiency, you're really going down the GI blood loss, lower GI endoscopy. And then if the patient's got normal hemoglobin, I think it's quite simple in that I think just sticking to obviously look at the MCV. If the MCV is high, you might want to be thinking about B12 or folate. But really for iron deficiency, you know, just for looking at iron deficiency in the presence of a normal hemoglobin, I think that ferritin and TSATs are enough. I mean,
yeah, we tended to do some studies with soluble transferrin receptors, and for the audience, for those who are not assessing this on a routine basis, we need to say it's opposite. The higher soluble transferrin receptor, the lower kind of a iron in the body. So in other words, we are using this, but as Professor McDonald said, this is not well established, it's not well evaluated. We can't really say that that this needs to be introduced into routine practice. Don't get me wrong, neither me nor any one of us is actually a specialist in this hematology. But what we learn, we better focus and stick whatsoever to these simple parameters, and then awaiting the results for mortality morbidity studies. We will see what comes out of these studies.
Linking with that, there is an interesting question about the parameters we use for diagnosing iron deficiency and say our lower limits of ferritin, say 25, 30 milligrams, already outdated. So the usual, let's say, normal cutoff for the population used in, I would say, probably in Spain, females is a bit lower than 30, for males is 30. So should we forget about that? Are we or need to apply different cutoffs, which is pretty obvious, but yeah.
Yeah, I think we should forget about that in heart failure patients, because you've got to understand what happens to ferritin in a disease in which there is de facto a chronic inflammatory state. So you're going to miss a lot of iron deficiency if you stick to the cut points in people who don't have another chronic disease. I think cut points of 25 and 30 are fine in gynecological situations in women aged 30, 40, or in GI blood loss, say, for other reasons. But in heart failure, I think you're going to miss a lot if you unless you go up to 100. Yeah.
Yeah, there are some other people that are asking because the link between iron and energetics, it is pretty clear. We know from several studies that at least ATP synthesis is really dependent on this iron inside cardiomyocytes, peripheral muscles, etc. Some of the audience actually make questions around it, and one of them said, what about treating patients with no symptoms and iron deficiency, but previous heart failure, say people with left ventricular systolic dysfunction, maybe half a year before, now in class 1, no symptoms, but you check out and you find iron deficiency.
Yeah, point well taken. On the other hand, what are the guidelines about is what is the evidence-based. Whatsoever, we have a clear evidence that with IV iron in iron-deficient patients, only in patients with heart failure and reduced ejection fraction. Okay, we can say maybe mid-range as well, because in this study 45 was a upper cut level for ejection fraction. With IV iron, we improve symptoms, we improve quality of life, we improve general well-being, but whether we improve the outcomes, we can't really say for sure today. I understand that the person who asked this question alludes to potential kind of a prevention, alludes to potential remodeling effect in those asymptomatic patients. To be honest with you, we do not have data yet to recommend this broader indication, so it would be my comment. I am not saying that I am not tempted to do this in clinical practice, but whether we can make this kind of a statement, particularly Professor McDonald, which is official, as a chair of the next guidelines, I'm looking for in 2 years from now. I'm looking forward to what is going to be in the next guidelines.
Yeah, I mean, I think there's always a grey area in clinical practice between what is in the clinical trials and in the guidelines and what people do in clinical practice, and there is undoubtedly indication creep as people get familiar with using intravenous iron. And I think the problem for us clinicians is who is really NYHA1 with heart failure, and they might be NYHA1 when they're sitting in your office, or they're walking between, the couch and the fridge. But if you actually put them on a treadmill, I think you'd soon find out that they were pretty breathless. So I think for patients who have manifest heart failure and presented, with some symptoms at some point in the past, even if they're not so symptomatic now, I think most people would be treating
very
everything.
Much agree, yes.
But I agree with you. The actual evidence, if you're being a purist, is not there.
But on the other hand, I fully agree with Teresa. If you put someone who tends to be asymptomatic, and if you challenge him, I'm not dramatic like a marathon below 2 hours, which can be done, but virtually one person in the world can do it. But why not we say this is very reasonable approach, because the treatment is safe. We can't really say this is a kind of a risk, putting patient at risk. It's well tolerated. And why not to try if you have a clear evidence that there is a iron deficiency? Fine, I agree with this.
You made a very interesting point about safety and about what is all related of using this type of drugs. And some people in the audience were asking about contraindications of intravenous iron in these patients, which are they? And also, should we combine intravenous iron and erythropoietin in patients with heart failure anemia? So
I think that the last question is probably easiest to answer.
Yeah.
For a patient who does not have chronic kidney disease or is not on dialysis, we should not be using erythropoietin. There has been a study, Red HF, which was used to treat anemic patients with reduced ejection fraction heart failure, erythropoietin versus placebo, and actually there was harm with doing that. So I think we shouldn't be using erythropoietin unless there are other good reasons, such as renal replacement, for using it. So that's easy. Yes, there are some contraindications if someone has had an allergic or a hypersensitivity reaction or an anaphylactic reaction to another intravenous iron product, then you shouldn't be using it.
Perhaps we also need to mention about infections.
Yes,
we
infection,
don't want in all the studies. You agree? That
Acute infection, yes,
we didn't, and we don't like those who manifest with acute infection, isn't it?
Yeah.
We are scared a little.
The bugs like intravenous iron as well. So I mean, there's a theoretical risk there, which hopefully.
That's interesting. I mean, there are many questions about. We all know that we and you stick to the guidelines and in terms of following what other recommendations. But some people is asking about different scenarios of the use of iron, and there are two scenarios that have been very common in the questions. One of them is acute heart failure. You are the person that can give us an answer, and the other scenario is preserved ejection fraction. So, Piotr, start. And
I start with acute. Teresa takes care of preserves, which is much more challenging. Let me start with acute. So, what we are now, so first of all, if we look at patients who are acutely decompensated and who are admitted to the hospital, more than 50% are iron deficient. And this is a clear evidence. I would say there are several studies very clearly confirming that, again, regardless, we are talking about patients with ejection fraction below 40%, over 40%, those who are decompensated, who are in the hospital, 60 to 70% of these patients demonstrate iron deficiency. Okay. Number two, when to start assessing it? I think that I'm not sure whether we should intervene and assess this in this acute stage, kind of a first 24, 48 hours. Well, although I have very strong opinion, I don't want to say that we need to do it, we don't have the evidence. The idea behind the HFrEF AHF study, which we just completed the recruitment for, was as follows. Stabilize the patient, assess the biomarkers, say day 3, 4, and if you have patient with iron deficiency, replete iron before discharge or just after discharge on this kind of a recheck visit within the first days after discharge. And then, if the patient still demonstrates, that exactly follows what Teresa wrote in her paper, if still patient demonstrates iron deficiency after 3, 4 weeks, first weeks, because this is a little bit different trial, then again replete, follow the patient 3 months and then 6 months. And this was the design of the study. We completed the recruitment, and the major issue of the study, the major aim was to not to improve the quality of life, because this is done. Main issue was to prove that it improves hospital readmission and mortality. We completed the recruitment. We are going to have the results exactly 1 year from now, a little bit less. So next year, by that time, we already know the result. This is a pretty big trial with 1,100 patients with acute heart failure recruited, double-blind, randomized study. So I think the result will come exactly in 1 year.
Expectations for the HFrEF study. Yeah. Some of the questions say that. What about HFpEF?
Yeah, that is a more difficult question. We obviously don't have any published trials yet of the use of intravenous iron in patients with HFpEF, so we can't categorically state there's an indication here. But again, like all things in clinical practice, there is indication creep, because in the guidelines it says quite clearly that really the only thing to date we can do for HFpEF is investigate and treat comorbidities and the underlying causes of HFpEF, which tend to be ischemic heart disease or hypertension. So I think that people are interpreting the guidelines as looking for comorbidities and treating them, and I think if they're finding iron deficiency, they are applying the same treatment algorithms, although the guidelines quite clearly say that it's for HFpEF. So I think we desperately need the evidence, because I think people will be investigating and treating iron deficiency anemia in HFpEF, iron deficiency and iron deficiency anemia. And the problem is, of course, we don't know about the long-term safety of that type of approach, which is why we do want clinical trials to tell us if this is A, effective in the long run, and B, is safe. So I think we're just in an evidence-free zone here, and we desperately need some studies to guide us.
I'm sure by the end Teresa will issue her guidelines. We would have at least one trial with acute and one trial with HFpEF. So it would be much easier to go for the broader recommendations.
Although I have to say, with looking at the other experience of HFpEF with all the other drugs that have been tried, what we'll see, I don't know. But
there's some comments around safety. You were talking about how important it is to assure safety, and there's an interesting question. Says you have clinical experience with patients and treating patients with iron deficiency with iron, and someone in the audience said, "Can IV iron therapy trigger heart failure decompensation?" What is your experience?
Not at all that I've seen. It's a very small volume of fluid that the iron is diluted in, and I've not seen anybody decompensate as a result of it to date.
Neither myself.
No.
We truly believe that this is rather prevention, treating patients with this decompensated heart failure, trying to make sure that they will not be readmitted. Most of cases are readmission due to volume overload. So we have strong opinion how it may work, but whether it works we will see. But I have never seen this such a bad scenario.
No, and from the data from the confirmed study, we saw the secondary endpoint. There was actually a prevention of readmission. So it seems that at least in these terms it's safe. And also some concerns about safety regarding creating pro-inflammatory state of iron, the risk of iron overload when you treat patients. So in your clinical experience, again, is iron overload one of the risks you face when you treat a patient with iron deficiency with intravenous iron, or not?
No, not in this scenario. We tend to find in chronic heart failure with HFrEF, we're talking about giving 1 or 2 doses, usually of intravenous ferric carboxymaltose, rechecking the ferritin. You must recheck the ferritin, and then if the patient is iron replete after 1 dose, you do not need to give any more. And I think people from the heart failure world are quite clued in on this, because remember, we're seeing patients coming from other areas of the hospital who've got sickle cell disease, who are having frequent transfusions or hemochromatosis. People are having to have chelation therapy. I think people are well aware in the heart failure world that iron overload can be a problem, and you certainly don't want to have another way of creating iron overload. So
exactly true.
And just to finish, because there are many questions that are still looking for an answer, but I think this one is very practical. How long do we replace iron deficiency? More or less, which type of a scheme we should follow on this type of patients?
Well, I think if you just put it, the guidelines, most national, international guidelines say check renal function once every 6 months in patients with heart failure. Just add it on to that. I think
that's
that would
exactly
be
what Teresa presented in this paper. Just recheck. Do not provoke by any chance chemochromatosis, iron overload. That's what we wish to avoid. But otherwise, follow the paper. Teresa is first author, and this is a very practically oriented algorithm. I like it. We actually have this on our walls in the hospital, and that's what we. And to be honest with you, Teresa, I am using this for HFpEF, which is not quite what we recommend. But anyway.
Okay, thank you very much. Well, we are now approaching the end of this webinar, and I would like to close this session by summarizing the key messages for your daily practice. First of all, we learned that iron deficiency is very common in patients with heart failure that has a negative impact on terms of functional and capacity, patient-reported outcomes, and also prognosis. The ESC guidelines recommend iron deficiency screening and diagnosis in all patients with suspected heart failure. Patients with clear indications for correction of iron deficiency are those still symptomatic, have HFrEF, and have ESC criteria for iron deficiency despite optimal medical treatment. In these patients, ESC guidelines recommend administration of intravenous ferric carboxymaltose in order to ameliorate symptoms and improve quality of life and exercise capacity. There are studies, as you mentioned, they're going to tell us about mortality and morbidity. We spent in that. And I would like just to finish to thank you, Professor Teresa McDonald and Professor Piotr Ponikowski, for your presentations. This program is supported by B4 Pharma in the form of an educational grant. You'll be able to watch the webinar on demand on the ESC website, and I really thank you for your attention. Okay, so I think we did